So the AAPI guidelines recommend selective rather than universal use of the new agents prasugrel and ticagrelor, and there's a number of reasons for that recommendation. First of all, although prasugrel and ticagrelor both demonstrated benefit over clopidogrel in the TRITON and PLATO studies, the benefit was relatively modest in absolute terms, with only an approximately 2% reduction in death, myocardial infarction, and stroke. The PLATO and TRITON studies also showed that both of these new drugs have a bleeding risk associated with them. And although in the clinical studies the bleeding risk appeared to be small, the panel were concerned that the bleeding risks in Atlantic practice could be larger, and potentially significantly larger, given that our patients are older and more complicated than the patients that participated in those clinical trials. One of the two drugs as well, ticagrelor, has some potential downsides that don't exist with clopidogrel and prasugrel, namely the requirement for twice-daily dosing and a small risk of new side effects, namely dyspnea and bradycardia, that are not seen with the other agents. And finally, Atlantic physicians really have no significant experience of using these new drugs, and the panel felt that a more cautious and selective introduction to clinical practice was the appropriate way to go.